Welcome back to Midwifery Wisdom Collective. Here we are watching more vlogs, more stories, more reacts videos, and we're in season 2. Welcome back. If you're new to our channel, hit subscribe, click that little bell button so you get notified when we produce another one. We are starting off season 2 reacting to a reacts video. I know it's very strange, but there are some OBGYNs, high-risk OBGYNs, who have reacted to common childbirth myths. Are they right? Are they wrong? Well, your Midwifery Wisdom team is going to take a look and tell you whether we support or debunk the myths that they debunk. Come join us.
Hi, I'm Dr. Laura Riley, and I'm a high-risk obstetrician at New York Presbyterian Hospital, Weill Cornell Medicine. My favorite thing to do is delivering babies.
And I'm Dr. Dina Goffman. I'm also a high-risk pregnancy physician. I'm the chief of OB at New York Presbyterian, Columbia University, Irving Medical Center. And today we will be debunking myths about childbirth.
I just want to acknowledge before we start that they've both acknowledged that they're high-risk physicians and they're about to be talking about maybe normal birth.
Mm. Ding, 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 ding. Leila has the discrepancy that I think most folks watching this show will not get. That's exactly it. We have got somebody talking outside their zone of genius. They cannot be expected to be accurate because they're not experts in it. And I think if we could do one thing in the maternity world, it would be this. If we're talking about a placenta that invades the myometrium and is a per creta situation, I definitely want her opinion. That is not my zone of genius. I don't have any expertise on that. Certainly doulas are not qualified to speak about that, et cetera, right?
Right.
But placenta medicine, length of labor, water breaking, that's our zone of genius.
Wide hips mean easier birth. This is a total myth. And what we see as your hips aren't even reflective of like what's going on with the bones in your pelvis.
I think one thing that is frustrating for people is they will say at 38 weeks, am I going to have a vaginal delivery? We can't tell because there's so many other factors that go into whether or not your baby is coming out vaginally. It's not just the baby's size. It's the baby's position. It's how well the baby tolerates holding its breath every 3 minutes. There's more to the story.
Hold on.
Okay, pause.
Hold on.
We're like, before you go, because maybe it's not going to be a secret. Before you go, the myth was wide hips makes birth easier. Okay. Thumbs up if you believe this. Thumbs down if you think it's false.
Yeah.
Not a thing.
Like, wait.
A thing.
Yes, no.
It's not a thing.
Yes, it's not a thing.
The external of your body has no bearing on, the false hips, the skin around the bones has no bearing on what the shape of the bones are.
Childbearing hips.
Not
baby making
not
hips.
A thing. So back in the original obstetrics takeover of maternity care in the 20s, 30s, 40s, 50s, when Western Americanized, mostly white male obstetrics was taking over the profession of delivering babies, they were coming to terms with the different variables that are during birth. And they came up with the 3 Ps: passage, passenger, and powers, as a way to contextualize how birth is successful or not. Passage is what they're talking about here, the wide hips. Passenger is baby, their tolerance and their position and their size and et cetera, et cetera. And powers is the strength of contractions. And mostly obstetrics' solution to all 3 problems is to give more oxytocin to solve the powers problem, give stronger powers. And remember, in the 20s, 30s, 40s, and 60s, the cesarean rate in the United States was 6.4%. So by and large, it was working. It was working then. In fact, most midwifery practices today would feel like they have a fantastic practice if their cesarean rate is around 6%. That's a really appropriate cesarean rate for this demographic, this population, where we value mother and baby's life, right? But overall, these 3 initial influences were the comparison about what was successful and what wasn't. And we at Midwifery Wisdom have just finished creating a new take on this. And instead of 3 Ps, we have 15 Ps. And so we're very excited to launch that soon. When we pull this apart, the passage, the P around the shape of the space that the baby makes his way through, is significant only for a few things. Number one, way back anthropological studies, 1800s, 1900s, there were early physicians talking about the shapes of the pelvis, and they gave 4 general shapes of the pelvis: anthropoid, gynecoid, platypoid, and there's one more I can't remember.
Android.
But android, that's mostly male. What they did is they thought, oh, a woman can only have one of these 4 shapes, and gynecoid is the only one that births normally. Bullshit, total bullshit. Now we know that actually there's whole kinds of hybrid shapes of pelvises, and you can't really even assess it without x-ray, and x-rays are not safe for pregnancy, and there's actually no point to even evaluate it because the hormones at play and the pressures at play change the shape of the pelvis and change the shape of the baby's head, and actually it's totally irrelevant. So from a true hands-on facilitating a dysfunctional labor perspective, the only things that really matter around passage are that the birthing person has total freedom of movement, because they have to move their body for their body to move. Like, that's self-evident, right? So if we're confined to bed, if we're laying on our back, the pelvis, specifically the sacrum at the back of the pelvis, cannot mobilize. So we have dysfunctional labor simply from the position that the person is being asked to labor in. It has nothing to do with the passage. It has to do with the environment that the passage is being subjected to. Yeah. Mobility is the one major component. Freedom of movement, self-directed freedom of movement changes everything, right? Which is a very strong argument for avoiding medications, a very strong argument for avoiding epidurals, because the epidural automatically confines you to bed and changes the shape, the ability to shape, shift, and all the things that happen. The other piece is time and patience. And this is what's mostly missing in obstetrics. This idea that certain percentage of people will not be successful birthing their baby normally is a ludicrous proposition. How could it be that we could move from a very evolutionarily successful birthing population to become less successful in the span of only 40 years? Evolution doesn't work that quickly. So the idea that we can't tell if you're going to have your baby vaginally or not is a ludicrous perception. Midwifery, and this is a hallmark of midwifery, believes that birth will be successful unless proving otherwise. We believe in the process, and we don't just believe in the process blindly, we believe in the process of supporting actual physiologic birth, which means, honestly, as little intervention as possible. And as the really well-known and famous Michael Rosenthal, obstetrician in the early 80s, who was really pioneering in bringing midwifery back in California, his really famous quote was, "The first intervention is the intervention of leaving their homes."
Mm-hmm. I love that one.
Which is why midwifery in home births, I mean, I'm all for birth center births, I'm all for midwives in hospitals, et cetera, but ultimately, one of the most intense interventions is birthing outside of your own environment. Mm-hmm. And I think people don't think about that very much. When it comes to passage, when it comes to the patience to allow the passage to mold and change, being in your own space, there's nothing like it. So we have to back up to the other ridiculous and erroneous statement that was just spoken by physicians, Ivy League, Eastern United States trained physicians, who just said one of the stupidest things I've ever seen on TV.
It's how well the baby tolerates holding its breath every 3 minutes.
Holding its breath every 3 minutes.
There's so many myths that she's just created. Like, there's no breath because there's no air in the uterus. So therefore there's no holding of breaths, first of all. Second of all, when a contraction comes, it lasts for about a minute. It does not cause a loss of oxygenation. It does not cause the baby to not be oxygenated. That's actually distress. The question that she's kind of asking is, how does the baby tolerate the labor? Okay, that is a valid question. That is a very valid question. In fact, it's the main reason why midwives and obstetricians have such a focus on listening to the baby throughout the labor. Because you want to see how's the baby doing. But it's not because we assume the baby is already in distress. It's not because labor itself is dangerous. It's not. Labor is actually incredibly beneficial for everyone involved. And that's a whole nother concept that we have to introduce to the American public, apparently. But labor is not dangerous to the baby in normal circumstances. The placenta lays on a bed of maternal blood stores. The water and the baby keep the placenta in place. Nutrients from a bed of maternal blood stores, these placental lakes, are transferred in the back of the placenta, including oxygen. During a contraction, the uterus tightens around, but the blood flow is not constricted. It continues as normal. It goes through the placenta to the cord. The cord goes round in the water, sometimes around the baby. Who cares? Doesn't matter. It's protected by thick Wharton's jelly. And it ends up at the baby, transfusing the baby with normal oxygenated blood, just like he was a week before. Before even labor happened, he was getting normal oxygenated blood at regular, appropriate intervals. To imagine that every contraction is dangerous to the baby is false, is misleading, and is actually, I think, reprehensible to share that with an American public. I'm actually shocked at that. And it's part of this mass psychosis around what is normal in labor and birth. And this is another reason why high-risk obstetricians should not be at the table talking about normal birth.
You know, high-risk doctors, they're looking for problems. When you go looking for stuff, you're going to find it.
The best position to labor and give birth on is your back.
That's a myth. What you might see on television or in the movies of a patient flat on their back is actually the worst position to labor and give birth in. We love to have patients be in bed, certainly on their side, but there's also a lot of opportunity to be sitting up and even to be walking around, depending again on the situation with your pregnancy, your baby, and your labor. There's the opportunity potentially to take a shower. Some people use birthing balls as a place to sit. Many places now have wireless fetal monitoring where you actually can even monitor the baby while you're moving around.
And a lot also depends on whether or not you have anesthesia, because once you have an epidural, it is fabulous for taking away the discomfort on your abdomen and those contractions, but it does in many ways weaken your leg muscles. So most hospitals will not allow you to walk around with your epidural in just because it may not be as strong.
It's a myth. And they were pretty accurate, and they were also really good at CYAing themselves. I mean, you know, to come on here on YouTube and say that every birthing person should be able to walk, eat, drink, hands and knees, take a shower.
They didn't mention
It's beautiful, right? It's beautiful. But that may not be realistic for a high-risk OBGYNs patient. And so they were really good at CYAing themselves in that sense.
There are people that need high-risk management and cannot necessarily employ the normal techniques of normal birth because they're not having a normal birth. They're having a very high-risk birth, right? So I agree with you entirely. And this was a fairly well-stated opinion. Again, you can just hear the lens through which it's shared, though, right? We love to have patients in bed on their side. Yeah. And I think the big difference here is teasing apart the risk status, right? So if we're low risk, then they don't have to be in bed at all. They don't have to be in any particular position. Giving birth in your bed was famously pioneered in the 1600s by a male obstetrician to make it more comfortable to deliver the baby, not more comfortable to labor. So we need to pull this apart and say, you know, if you need to be in bed because you are high risk and you have lots of medications or pain medications or induction medications or monitoring or something that needs to happen because you're very high risk, then that's an appropriate place for you. But if you're not high risk, we need to erase that cultural conditioning of where the bed needs to be. And I think they did a pretty good job of naming that.
And there's still so many blends though, too, right? Like as a doula supporting in hospitals, I have seen the walking epidural, which is just fentanyl through your epidural, no Novocaine or Rivocaine or the numbing agent for the legs. And yes, they're like vomiting and dizzy because of the fentanyl, but we are able to get in the tub and walk and be on the ball and hands and knees and squat and move. And even with a full epidural, which has the numbing agent and the pain medication, we can still be hands and knees with a squat bar, all kinds of changing positions. But just from like real world doula experience, that is not discussed in your prenatal care. It's not discussed that I want you to know that your choice of catching your own baby in a squat position with an epidural, I'm not going to allow, because that's the truth. They're going to, what we call in the birthing space, bait and switch pretty intensely in this absolutely all of these options, all of these things. And then you get the full epidural and your legs are so freaking heavy that we cannot get you up to a squat with the squat bar. And you're so loopy and shaking and vomiting from the epidural that you're not able to catch your own baby. And it is just simply something that in this video, specifically, was undersold.
Yeah,
highly undersold.
Well, epidurals in general are undereducated. People are undereducated about them. 3% don't work at all. 6% have breakthrough pain on one side. Many of them have these side effects that you're talking about, vomiting and dizziness and feeling uncomfortable. And then there are quite a few that experience after effects, like the epidural headache or spinal fluid leak, and have days and weeks of recuperation where they can't be with their baby. And I think if more people understood what they were actually choosing and what they were losing because of that choice, the whole thing would be quite different.
Meredith, you've had an epidural, right?
I mean,
I'm sorry, pull in some personal story here, but I don't know.
What was that like?
Bekah, Augustine, ourselves, we haven't had one. So what was it like?
Actually, it was interesting, I guess, to say the least. So they placed it incorrectly the first time. I could feel that it wasn't straight, but they asked me like where I was feeling it. And so they had to reposition it to get it to be in the right space, which was not pleasant because, you're like in labor and And for me in particular, because it was like a non-emergent emergency, hey, this isn't an emergency, but your people should be here in 30 minutes because that's how long it takes to prep the OR. So, trying not to let me freak out, but, so I don't know, my situation, I had a very complicated and high risk pregnancy. So all those things were necessary for me. I had already had a prenatal surgery. So I had a healing incision already that was only 6 weeks old. And so it was real interesting. So you're already not feeling great, and then you're worried because you have this baby that's not supposed to be here yet, but they're coming anyway. And you're like, for me, I'm in the hospital by myself waiting for my loved ones to come join me because they're like, well, you'll stay here till you have a baby. We don't know when it's going to be. So that kind of thing. But I had a pretty good team, so I feel like I was well supported. But definitely things that they don't tell you, oh, you're gonna, it rains and you're gonna feel this sharpness in your back occasionally, how arthritic patients sometimes can get those pains in their joints and things like that. Some people still have those effects in their back, you can still feel where that was. I've also supported other people too with their epidurals and had this crazy itchy reaction. So you've got this newborn baby and they're trying to crawl out of their skin, and then it's just, there's
actually a pretty common side effect is the itching.
And I've had some people be like, the itching was worse than the contraction. Can we take it away now?
You're laying out, taking away the pain for throwing up, dizziness, can't move, itching, long-term hormonal
risk
change.
of more interventions.
It's like those commercials for whatever medication, and the risks are. Blah, 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 blah.
Let's
You know.
make an ad for epidurals. Let's make an ad for epidurals, just like the
I mean, there
regular
really
pharmaceutical-
should be.
I had a
was- yeah.
cesarean, so my epidural wasn't for a vaginal birth either. So I
Heavy dosed.
yeah, like
Really
could not
bolus.
feel anything below.
which, let's just change gears for a second, is amazing. That
That's
you
what I was
can
just gonna
have
say. Like,
a birth by cesarean and be awake
And be awake.
present and meet your baby and out of pain. And it's actually amazing, right? So all we're advocating for is good informed decision making and the separation of risk assessment, right? Normal people do not need interventions. High risk people need all of them, and they need to be fully informed of them. And I appreciate your personal story, Meredith. Really great.
which is what these doctors didn't give, right? Like,
Yeah.
we really, I will fully support someone in their choice to have an epidural.
Yeah,
Please
definitely.
inform them on
Yeah.
what it could happen.
Need all the
Absolutely.
facts.